Thank you, Dr. Budvali, for the kind introduction, and thank you and Dr. Lang and the organizing committee. It's been a privilege to be invited here and talk about pediatric low-grade glioma and diffuse midline glioma. So I'm trying to, okay. This is the right setting for the viewers?
Now you will have to switch to presentation mode on the display settings, Dr. Zaky,
Okay.
on the top.
So,
yeah, just swap the presenter mode if you will.
Good.
There you go. Perfect. Thank you.
Okay, so actually, Leo have made my mission much easier by talking about the pathology. So I will focus more in the clinical aspect and management of these two different tumors, which one have a good outcome and the other one have really poor outcome. And we'll try briefly to talk about background, biology, and molecular subgroup, treatment and outcome, and maybe shed some lights in the innovative therapies for these two tumors. So the pediatric low-grade glioma, it's the most common pediatric CNS tumors. It's about 30% of pediatric CNS tumors, about 1,500 new patients diagnosed in the US every year. Most common location is the cerebellum, but can arise in other midline location like optic nerve and thalamic and spinal. Histologically, Leo spoke, in details about this. So it's a basket diagnosis, including astrocytic and glioneuronal and oligo tumors. The main management is individualized based on the clinical finding, the neurofibromatosis status, and the tumor location. And, below is the 4 different astrocytomas that commonly encountered in children. So for the pediatric low-grade gliomas are primarily managed with surgery, with gross total resection often leading to excellent durable disease control. For the non-resectable ones or the one who have progressive tumor after resection, radiation or chemotherapy have been used to improve the disease control. Recently, BRAF filtration is the most common detected genetic abnormality in this tumor groups. Other alteration or mutation, including NF1, FGFR, and MEB, as Leo discussed in details earlier. Malignant transformation is very rare in pediatric. It's, about 12 to 15% compared to adult, which is like 50 to 70%. And this is the Kaplan-Meier curve for the 4 different astrocytomas. You see very good outcome for the pilocytic astrocytoma, with expected 10-year survival about 90%. And here in the bottom is the table showing the BRAF fusion and BRAF mutation, which is basically BRAF fusion is more common in the cerebellum compared to the BRAF mutation, which is more common in the supratentorial location. And also their incidence differ by different histology. So for example, in the pilocytic astrocytoma, 2/3 will have the fusion, while in the PXA, 3/4 will have the BRAF mutation. This is basically the underlying biology of pediatric low-grade glioma. MAP kinase is the main driving pathway, but the AKT pathway is also activated, and they both crosstalk. And there's different mutations and alteration, as we talked about it earlier, including BRAF fusion is the most common, BRAF mutation, and NF1. Also some translocation like the FGFR and NTRK, which we'll discuss briefly. So early attempt to dissect this tumor molecularly. This is a study done for 60 pediatric low-grade glioma and glioneuronal tumors. have detected the MAP kinase pathway as the most active pathway in low-grade tumor in children. Subsequent study, this is done by sick children where they look in 1,000 samples of low-grade gliomas. They basically dissected into 10 molecular subgroup depending on the underlying biology. And as you can see, 4 groups that have mutations like the BRAF mutation, FGFR, IDH mutation, and very small group, this is controversial, that have the histone mutation and still counted here under the low grade. For the one that have the fusion, the most common is the BRAF fusion, the one with KF1549. And there is also the FGFR and the MIP. And each of these group has its own outcome. So typically the one that have the fusion have far better outcome compared to the one with the mutation. As you can see here, all of them has very good overall survival compared to the one that have BRAF mutation or the histone mutation. So traditionally, the oncologist in this webinar familiar with the standard of care for low-grade glioma in children. And this is basically came out after the children oncology group study where they used 2 different arms, carboplatin vincristine versus 4 drugs. And this study became the standard of care. These patients, 40% have objective response and progression-free survival was like 42% and good overall survival. So this is the standard of care now for children, new diagnosis, low-grade glioma with progressive disease. The other alternative chemotherapy treatment include single agents, vinblastine or temozolomide, or a combination therapy like vinblastine and carboplatin or carboplatin large dose, or Avastin and irinotecan. So there is 8 or 10 different lines of chemotherapy that can be used in pediatric low-grade gliomas. Most recently with the new genomic information coming with more detection of the BRAF fusion and alteration, a lot of phase 1 start to investigate the role of MEK inhibitor and BRAF inhibitor in pediatric low-grade gliomas. And here's 3 different phase 1 trial. Sulamatinib is MEK inhibitor that's being used in progressive low-grade glioma in children and have in heavily treated patient, the objective response was 35%, and the one that have the fusion have better outcome than the one that have mutation. Other MEK inhibitor, which is tramatinib, have similar objective response of 45%, and they both have some tolerable side effects, mainly dermatological. Also, phase 1 trial for BRAF inhibitor, the BRAFINIB, showed similar objective response in BRAF mutated, about 45%. So these are promising in progressive low-grade gliomas. Most recent presenting data from sick children group was Eric Buffet. He presented this in the ASCO. He combined the BRAF inhibitor and MEK inhibitor in low-grade glioma and compared this in a trial versus the standard of care carboplatin vincristine. Very promising data. He showed the objective response is superior, like 47 versus 11% in the standard of care, and clinical benefits and better overall progression-free survival, and even less side effect, like 47% compared to 94. So this promising data, but need to be validated in a phase 3 trial. Still, lots of question about the role of target therapy in low-grade glioma, like what's the length of therapy, what's the role in new diagnosis, and what's the long-term effect. We know some of these drugs cause skin cancer, And what's the mechanism of resistance for the patient who have progressive disease, which is almost 1/3 to half of the patient don't respond to this target therapy. So this to be determined, but it gives promise for the patient who's really failed standard of care. Now I'm going to shift gear to talk about the diffuse midline gliomas. So this is a new name. The old name is DIBG, but since the WHO classification, they lumped multiple midline tumors under this category. So it's a heterogeneous group of diffuse infiltrating glial neoplasm. It's WHO grade 4. When they have the histone mutation, this group constitute about 10% of all pediatric CNS tumor, and there is about 500 new case diagnosed annually in the US in all anatomical location. As you can see in the MRI here, in the brainstem, can occur in the cerebellum and in the thalamus, in also spinal. Typically, they are diffuse infiltrative by biopsy before having the histone mutation. It could be astrocytoma grade 2 to 4, but once the histone mutation or alteration is detected, they become, according to the WHO, grade 4. Treatment, these are non-surgical disease. It's inoperable, meaning no gross total resection, because they are in eloquent location, except some area you can attempt, like in the cerebellum or in the thalamus. Chemotherapy is ineffective. Focal radiation is usually provide a transient response, and clinical trial and or comfort care are other standard of care. So this is one tumor you can simply send the patient to hospice without any intervention. Prognosis, unfortunately, there is no long-term effective treatment, with the 2 years overall survival less than 10% and median survival about 11.2 months. And this is #1 cancer-related deaths in children with CNS tumor. I'm adding here, one of my patients was autopsy. He had remarkable response to chemotherapy with 60% reduction, but he died in the ICU from a respiratory failure because of the necrosis that developed. And, the autopsy was showing like grade 2 astrocytoma. So it's not the grade of the tumor that kill, usually the location. So what is the mechanism of tumor genesis? Basically, recently, with all the molecular dissecting of this group of midline gliomas, the histone mutation was recognized as, the driving force for the tumor formation. So what are these histone mutation? We know, that, the chromatin is basically DNA wrapped around histone, octamer, and there's different histones. Histone 3 have amino acid tail, and in the position 27, there is lysine. And when mutation happen, the K27M, lysine will be replaced by methionine. So there will be loss of the trimethylation mark. This will lead to decrease of the genome repression and lead to increase the transcription, some of the oncogenes, which, with the interaction of other genetic alteration in the IBG, will lead into tumor genesis. And so we know histone mutation is common as up to 70 to 80% in midline gliomas, depending on the location. But there is other alteration encountered, include P53 or ECVR1 mutation. There is also some amplification of PDGFR and the cyclin D4 and 6, and deletion of the CDKN2A. So all of these interact together, cause the tumor genesis, leading to the midline gliomas. early attempt to dissect this tumor molecularly using gene expression and methylation profiling has yielded 3 molecular subgroup of the IBG or midline gliomas, as you can see here. The majority are the one that have the histone mutation in 70% of the time, and 12% is have driven by the NMEC, and there is a small group, about 10%, that they are silent. There is no mutation identified. Each of these group have its own molecular characteristic, but overall the outcome is still poor, with the majority succumb to their disease in 9 to 12 months. Most of the long-term survival of midline gliomas, they fall under the silent group, where there is no histone mutation or NMEC. So early study try to investigate if the histone mutation is good or bad outcome. And this is basically from the HIT German group. Look at 85 centrally reviewed DMG, including thalamic and brainstem and spinal. They identified the histone mutated group as a very poor outcome, with expected survival about 9 months compared to the wild type. And there is, different histone mutation. The most common is the histone 3.3, can happen in 66% in this group, while the other histone 3.1 incidence is 7%, and 1/3 is like wild type. They also look if histological grade, like anaplastic versus grade 4, have any difference in outcome, and there was none. Also, different anatomical location, there is no difference in outcome. And even the one who have partial resection in the thalamus versus biopsy in the brainstem, there was no different outcome. So that's why this tumor is basically surgery doesn't play a role, and histology and location is insignificant for outcome. This is the children oncology group study try 2 decades ago to treat the midline gliomas as high-grade gliomas, where they use temozolomide with radiation, followed by maintenance temozolomide. That was a kind of a disappointing study that showed poor outcome, with 1 year event-free survival about 14%, and the overall about 40%, and median survival is about 9.6 months. And the conclusion of the study, temodar or temozolomide did not improve the outcome compared to the standard of care radiation alone, as you can see here in this Kaplan-Meier, and it's actually added more toxicity. So since the publication of this study, the standard of care for midline glioma is radiation alone. And we still see some, neuro-oncologists in the community still use temodar for histone mutated midline glioma, but it's, unfortunately, it's useless. This is another retrospective study from a Chinese group, look at midline gliomas, both in adult and pediatric, reached the same conclusion. The addition of chemo to radiation did not have any significant outcome to radiation alone. So again, for this type of tumors, it's radiation only. This is a table illustrating most of the therapeutic trials done over the last 2 decades in DIBG using different modality, including increase the dose of radiation to 75 gray, use high-dose chemotherapy, use radiosensitizer, and some immunotherapy trials. Still, the outcome, it's about 12 months survival, unfortunately. So try to give you some hope. We'll discuss briefly some of the innovative therapies that are available for the midline gliomas, and quickly I will shed some lights in target therapy, epigenetic modifiers, and immunotherapy. So for precision medicine or target therapy, there is multiple genetic alteration has been detected in the diffuse midline gliomas, including mutation in the ECVR1, which is altered in 1/3 of the patient, and there is ALK inhibitor 4 available. Also, BDG4 amplification and EGFR overexpression, some signal transduction like AKT pathway activation. There is an inhibitor 4 now undergoing in a phase 1, and there is BI3 kinase inhibitor also under investigation in phase 1. Also, some of the cell cycle can be targeted in midline glioma, including CDK inhibitors and aurora kinase inhibitors. So a lot of ongoing efforts in the community by multiple consortium try to use these new small molecules in phase 1 to change the outcome and move the needle for this frustrating disease. Other strategy is epigenetic modifiers. So we know the histone mutation lead to change in the epigenomes and lead to the tumor genesis. So using these new compounds is try to revert the signature of the histone mutation. And there is different group of epigenetic modifier. There is some writers like the histone acyltransferase, some eraser like histone deacetylase, and some reader like the bromodomain extended terminal family. So all of these, there is a small molecule that can be used to target these epigenetic modifier. And in some of these used in preclinical data with some promising results, like panabinostat, but unfortunately they fail in phase 1. But there is a couple of drugs like the GSK and the JQ1, they are under investigation now in phase 1, and hopefully they will be incorporated in the future in combination therapy with other drugs. Another new molecule that under investigation now with some promising result is the UNC201. This is basically a dopamine receptor inhibitor, which is basically overexpressed. The dopamine receptor 2 is overexpressed in midline gliomas. And this drug is orally active and cross the blood-brain barrier, and it causes tumor killing through different mechanisms, include integrated the stress response or inactivation of the RAS signaling pathway, and eventually lead to p53 independent tumor cell apoptosis. Some early results by both adult and pediatric had some early preliminary promising results. So 2 of the adult patients had a long-term stabilization of disease with objective response, as well as the IBG patient. And this is the published 3 years ago. This is the 2 adult patients who have remarkable radiographic response that last 50 or higher weeks. And this is one of the DIBG patient who have remarkable tumor reduction and even clinical improvement. But eventually this patient, like 14 months from diagnosis, had further disease progression. Right now, there is a couple of ongoing clinical trial for this compound, including combination therapy with BI3 kinase inhibitor and a new generation of the UNC201, which is the UNC203, UNC206, I'm sorry, which have better pharmacokinetics. It's under investigation. Lastly is immunotherapy. There is different targets have been identified in DIBG and midline gliomas, including the histone mutation itself and GD2, which is a ganglioside overexpressed in midline gliomas and other tumor like neuroblastoma. EGFR is another target, is overexpressed, and 2 of the immune checkpoint include P7H3 and BDL1. They all under investigation in phase 1 trials. And there is different strategy for phase 1, including CAR-T, dendritic cell vaccine, monoclonal antibody, radio-labeled monoclonal antibody, checkpoint inhibitor, viral immunotherapy, and others. And this is the current active phase 1 trials using immunotherapy in midline gliomas. including the CAR-T and the viral immunotherapy, DNX. And this is basically a collaborative efforts of medical center in Spain and our esteemed scientist here, Dr. Fuiho and Gomez, where they developed this DNX viral that injected into the tumor as seen here in the MRI through stereotactic. And Dr. Alonso presented this recently with some promising early results. And we're hoping this will move forward. Hopefully this will be a game changer for this disappointing disease. I will end up here and will be happy to take any question.